Good afternoon, everyone, and welcome to today's workshop, Adoption of Health Literacy Best Practices to Enhance Clinical Research. We thank you for taking the time out of your day to join us for this important session. I am Lawrence Smith, Executive Vice President and Physician-in-Chief at Northwell Health and Dean of the Donald and Barbara Zucker School of Medicine. I also chair the Roundtable on Health Literacy at the National Academies of Science, Engineering, and Medicine. In today's workshop, we will explore the importance of communicating clinical research information in a language that is understandable to the public and appropriate to their level of health literacy. We will hear about what resources and strategies are out there for communicating that information, and we will also hear about how clinical research information can be integrated into care and community and enhance research participation and engagement, as well as the quality of the clinical care. This webinar is hosted by the Roundtable on Health Literacy. For those members of our audience who may not be familiar with the Roundtable, it is a convening body comprised of health literacy experts from academia, healthcare, pharma, community-based organizations, and other fields. The Roundtable holds public meetings, as this one, to share promising and best practices in cutting-edge research around specific topics in health literacy. I'd like to thank Rose, Kelly, and Christy, the staff of the National Academies, for their assistance to the Roundtable in putting on this workshop. Today, we will have several panels. We will hear an opening from Barbara Bira, then hear from Dr. Elizabeth Kahn about the importance of this issue from the patient perspective. In the next panel, we will hear from two speakers about strategies and tools for communicating clinical research in a health literate manner. Their presentations will be followed by a Q&A. Our final panel will focus on translating this information into care and community settings. This session will be an hour-long panel discussion with our panelists in conversation together. As we go along, please submit questions to the Q&A function at the bottom of your Zoom screen. We will do our best to address them. Before we begin, I'd like to remind everyone that this webinar is being recorded and will be archived at the Roundtable website, nationalacademies.org/healthliteracyrt. Please note that the recording will be posted to that webpage about 1 week after the webinar takes place. All of our panelists and moderators' full bios will also be posted to this webpage. I'm now going to hand it over to Barbara Bira, who will say a few words about the workshop and what it seeks to address. Dr. Bira is a hematologist, oncologist, and professor of medicine at Harvard Medical School and the Brigham and Women's Hospital. Dr. Bira co-founded and now leads the multi-regional clinical trial center of Brigham and Women's Hospital and Harvard, which is a collaborative effort to improve standards for the planning and conduct of international clinical trials. Thank you, Dr. Bira. Please go ahead and get us started.
Thank you. Thank you so much. And just to say that this is also being closed captioned for those of you who would be, for whom it would be useful to be able to read the script as well. And I want to thank the National Academies as well, Larry, for that wonderful introduction, and Rose, Kelly, and Christy for all the support in getting this to be possible. Could I have this first slide, please? And, you know, my slides as they're coming up. Let me just say that we have no conflicts of interest, and the Multi-Regional Clinical Trial Center is supported by grants and as well as by contributions. Could I have the third slide, please? So, you know, as we were thinking about this panel and this workshop today, you know, it's obvious to everyone on the call that the diagnostics, treatments, and therapies are the result of research and clinical research that involves human beings, and that research should reflect the participants, or the participants in the research should affect the affected population or those intended to use the intervention or avail themselves of the benefits of the treatment. And that there are legitimate and varied reasons why individuals have concerns about research and have questions about research, and they should have questions about research. And those questions should be addressed as a precondition to consideration for participation. We want to make sure that participants enter clinical trials voluntarily and that they understand what they're contributing to and the risks and benefits thereof. But equally, that we make sure we engage those participants appropriate to the trial and to the condition. It depends upon a common understanding and a shared exchange of information, and it depends upon trust between the investigator presenting the information or the clinician investigator presenting the information and the person. And we all are committed to health literacy, which includes, of course, not only plain language, but also numeracy, imagery, design, and other principles, including a culturally and linguistically appropriate communication, and that supports communication and understanding, but is itself only part of the answer. Could I have the next slide? So we take the position that comprehension or understanding is the responsibility of the communicator. You know, we often talk about low health literacy or limited English proficiency, and that is essentially a blame the victim in my opinion. It's not the responsibility of the person receiving the information to make sense of it. It's the responsibility of those of us communicating to make sure that we're understood and to continue to try and make that clear until we're sure that the person whom we're talking to or communicating with really does understand and has exhausted their questions, and we eliminate that lack of understanding. So we need to make sure that the individuals are comfortable asking questions and understand that which is imparted to them. And we have to make sure that we include as those people whose principal language is other than English, another concern and challenge that we need to address. It is a systems problem. We need to commit to that as a group. And part of what we're going to be talking about today is the how of how that can be possible. Could I have the next slide, please? So, you know, understanding health information and shared decision-making and how it applies in research is important for recruitment, for access, for consent conversations, as well as for patient-reported information, patient instructions, outcomes, et cetera. And it has to come from an understanding of a research context that can result in value concordant decision-making on the part of the participant. Health literacy can help increase engagement in research and demonstrates respect and supports the principle of justice. And both the Common Rule and FDA require information that is given to the subject or the representative shall be in language understandable to the subject or the representative, and that includes all sorts of all patient-facing information. Could I have the next slide, please? So, you know, I've mentioned that it needs to be culturally and linguistically appropriate for the population. There is wide variation among different populations that is true not only geographically, but also culturally. And that outreach to the communities must be authentic and include those communities as partners so that we can make sure that we use terms that are understandable to the population. When we started doing this work, we found that when you talk about clinical trials in certain communities, they hear it as criminal trials, and that using the word clinical studies is much more impactful than clinical trials, which is not, you know, and is less often misunderstood. Getting this right is helpful for everyone, and thinking about the fact that we use terms differently and that individual groups, you know, pharma, investigators, institutions, and the materials may use the same words in different contexts and mean them differently is presenting a problem in the same way that we need to sort of unify the language in order to make it easier for people to think through how to communicate. So what do participants, patients, and caregivers need to make the informed decisions that we're asking of them? How do healthcare providers make research a part of their conversations? And how do those stakeholders need to support participants before, during, and after a research study? Today, we're going to hear about that challenge and many efforts to address that challenge, including the introduction of standards and tools, including the patient experience, and including sort of an approach to thinking about that, working on this together, that I hope we can all benefit from. And with that, let me close and welcome everyone, invite you to put in your questions and chat, and introduce Elizabeth Kahn, who is a wonderful collaborator, friend, and enthusiast for this work, who will discuss her personal journey. So Elizabeth, why don't you introduce yourself in the way that you'd like to and begin.
Thank you so much, Barbara. I'm really happy to be here today, and I'm really happy that I have an opportunity to tell you a little bit about my experiences, both as a patient, as a family member and caregiver, and as someone who works professionally with patients and families and caregivers. And you can see, because of the pandemic, I've had to let my hair grow out from when I had that headshot done. So I have a whole number of different experiences that have to do with this work. And it started with my diagnosis with early stage triple negative breast cancer in 2007. And I ended up in a clinical trial for treatment of that cancer and did very well, but it was a long haul. And so that was one of the things that I had experience with. And I also have been a caregiver for other people in my family with cancer, including my mother, who's 89 and has had chronic lymphocytic leukemia for 30 years. So I haven't been the caregiver for all 30 years, but for the past 10 years, I've been pretty much the person sort of on deck for her. And also in my professional work, I'm the program director of a small community-based nonprofit named Cancer Connection in Northampton, Massachusetts, where we provide a wide variety of mostly support services for people affected by all kinds of cancer. And we do not give medical advice, but we often end up talking to people about their medical choices, how they're going to make choices. And sometimes they're interested in being in clinical trials and participating in research. So I was trying to think of a story that would kind of convey to you like what this is all about from the patient perspective. And when I met my oncologists back when I started my breast cancer treatment, I decided that I would make a document. It was about 2 or 3 pages that had my personal medical history, my family medical history, my medications, and so on, to share that with my oncologists when I met them. So when I met my medical oncologist, he introduced himself. He said, put on this little gown and I'll be back in a few minutes. And I said, I prepared a document for you with this information about my medical history that might be helpful to you. So he leaves the room, I put on the gown, he comes back in the room and he says, thank you very much for that, document. It was really helpful. And I really liked the font. And because I worked as an editor, my ears perked up at that. And I said, well, did you like the size or the style? And he said, oh, I like the size. And the size was 9 point. It was 9 point Times New Roman. So my oncologist said, I like 9 point Times New Roman, which, if you know anything about font families, is like even smaller than 9 point in other fonts. And I thought, oh, that's great. I can really work with this person. And we had a great time working together. But it really pointed out to me that like communication works best when all the parties involved are sort of on the same page about not only what is going to be communicated, but how it's going to be communicated. Because for most people, 9 point Times New Roman is what they ignore. Like that's the thing you don't read. That's the footnotes. That's something that is not for me. And so it made me think about how in the area of clinical trials or clinical research, or even getting people to pay attention to health information, as we all know, it has to be communicated in a way that works for everybody who's involved in the communication system. And when it has to do with health or disease or something where there's a problem happening, like we're not all on the same page. We're really, really not all on the same page. And so we have to really, I think, account for the fact that we're not on the same page, and we need to try to overcome those differences which are there from the very, very beginning. So when I talk to people about, how to communicate with patients or how to make things more patient friendly, I try to go back to sort of what are my experiences, what are the experiences of the people that I have around me, and how can I sort of learn from that and come up with principles that are going to be sort of guiding principles for other people. So the things that I think about, they're not rocket science, but they're easy to forget. And, number one is like, slow down, because whoever you're trying to communicate with, this is new to them. They don't know this. They are not used to taking in this information. And as we know, it may be like emotionally fraught. I work with people in my job who just got a cancer diagnosis, and we sort of say like, well, they're just in free fall to the bottom of the universe right now. They think they're going to die in 2 weeks. And that's probably not going to happen. But we just try to float down to the bottom of the universe with them and sort of let them know that they're not alone, that other people have gone through this, and that other people have learned to cope. And often when we see folks who are going through a second diagnosis, or they're supporting someone after they've had their own diagnosis, like, they do it much better because now it's the second time around. But a lot of people are the first time around. And so it's really all new for them, and it's emotionally fraught information. So slow down. The second thing is like, speak up. And I don't mean like yell, but like, make sure that you're communicating clearly and that you're saying what needs to be said in a way that the other person can hear. My mother has hearing impairment, and she has excellent hearing aids, but I find even in sort of healthcare situations where it seems like people should be sort of trained about this, that often folks, they don't speak up. They literally don't speak up. And I think, well, cancer is a disease of age. Most of the patients are sort of on the older end of the age range where, people are starting to lose their hearing. And even if you have great hearing aids, it's not great. And of course, with the pandemic, folks are wearing masks, which doesn't help. But it's sort of like, what is the metaphorical equivalent of speaking up so that the person that you're trying to communicate with can actually hear what it is that you're trying to say? You're speaking to someone who isn't used to kind of living in this space, whatever the space is that you're trying to communicate to them about. And the third principle is sort of like, goes along with slowing down and speaking up, is in person, I would say, orient your face to the other person's face. And since we're not always face to face, like, what I mean by that is like, orient your humanity to the other person's humanity. Like, imagine that the person you're communicating with is somehow like not a stranger, not a subject, not an object, but someone that you care about. Like, this is your mother, this is your sister or your child or your friend. Like, how is it that I can sort of philosophically and emotionally recognize the human reality of that person, the human rights of that person, and help them with what might be an uncomfortable situation or even a crisis that they're dealing with. And then, of course, once you have sort of figured out how to approach someone, is figure out how to give the information in the chunks that are the most important, because they can't take it all in at once. And different kinds of information are important at different kinds and at times. And I think this is really challenging when we get to the issue of like consent documents, because documents per se give an enormous amount of information in a format that the average person isn't really prepared to take in. Like, those of us who are in this presentation or who are watching this presentation, we probably have many, many years of education of learning how to read documents, learning how to interpret written information, understanding about headings and subheadings, and how do you kind of organize your way through these large written documents. But the average person, even a highly educated person, is not necessarily doing that on a regular basis. It's just not a familiar place to them. So organize the information in chunks and be prepared to repeat it and give people many, many opportunities to go over the same information again, even if you think that you've already given it, even if you think that they already understand it. make sure that they have an opportunity to go over it again and ask questions and check in with them to find out if they have understood it or not. And one of the things that comes up a lot in our conversations in the multi-regional clinical trials programs is the idea of having trained clinical trial navigators. I know that there are such things in certain situations, but navigators that would really help people in trials or get into trials, but also stay in trials, because there's often in clinical trials, there's often a lot of additional testing, there's additional scans or biopsies or procedures. And to have a place where people could go to ask their questions, even if their question seems like a foolish question, or they have to ask that question 10 times or 100 times. And we would all love it if, like, our primary physician or our oncologist could be the person that we could ask that question to, but we know that that's not practical. But I would love to see, like, really more use of trained clinical trial navigators for people in clinical trials to help them get into it. So I just, had two or three other things that I wanted to sort of just little anecdotes about sort of the nature of being the patient or the caregiver. So I decided I would grab my mother's most recent clinical trial document. So she's had CLL for 30 years. She's had 9 lines of treatment. She's been in 4 trials. And so the most recent trial document, the original one was 28 pages. And then we just got past the 1-year anniversary. So they had to, re-up the signatures. And so then it was 31 pages because there's some additional studies that are part of it. And so I looked at it and I realized that it has actually a very nice summary at the beginning that's about 2.5 pages of, like, what the trial is about. But one of the things that's very problematic to me is that you read the summary of the trial, which is 2.5 pages, and then without a break, without a visual break, it goes into the long description. So when you're reading it, even if you're used to reading these documents as I am, you don't notice right away that, oh, like, now I've gone into the whole description. And I thought, well, why couldn't we have a page break there? Or why couldn't we have it say, this is the end of the trial summary, so that the person reading it could go, oh, like, this is really what I need to understand today. And then maybe tomorrow I can look at this other document. And another thing that I would like to see in trial documents specifically is something as far as, like, a consistent presentation of, like, a calendar that looks like a real calendar, and not just a written list of how many times we're going to take your blood and how many times we're going to stick a needle in you and how many times we're going to do a scan, because visually it might be easier to get that information if it were actually in a sort of calendar, like visual calendar type format. So those are just 2 things that are sort of at the front of my mind right now. So I'm going to stop with those things and say that I'm really happy to be here, and maybe I'll have some comments later in the program based on what I hear from other folks. Thank you so much.
And thank you so much, Elizabeth. It was really just perfect, and a perfect introduction to say, what you experienced in the forgiveness that you had for your clinician who liked 9-point New Roman, whatever you said, instead of saying, I never knew you in that way, is remarkable, and just shows how sort of understanding is bilateral. With that, let me just say thank you again. We look forward to your further contributions, and let's move on to the first panel, which I think will be introduced by Katrina. Katina O'Leary is the president and CEO of Health Literacy Media and is going to introduce the panel today.
Thank you so much. I'm happy to be moderating this first panel, Tools to Improve Health Literacy of Clinical Trial Information. We're going to hear presentations about 2 resources for how to discuss clinical research information in a language that's understandable to people and that promotes health literacy. Following the 2 presentations, I'll be moderating a brief Q&A with our 2 moderators. So to our audience members, please remember to use the Q&A function throughout the presentations to send us anything that's on your mind so we can guide the questions. So the first thing I'd like to do is introduce our first speaker. So the first presenter on this panel is Sylvia Bedorf-Cassis, who will share, who will share information about the clinical research glossary that's been developed by the Multi-Regional Clinical Trials Center, or MRCT, of Brigham and Women's Hospital in Harvard. Ms. Bedorf-Cassis is a program manager at MRCT. She has 20 years experience in clinical research. Her work in and outside of MRCT has focused on efforts to make clinical research more understandable to patients and participants. Thanks for joining us.
Thank you so much, Katina, for that really nice introduction, and thanks to everyone for being here today. Next slide, please. It's such a pleasure to be able to share this information with all of you. So just quickly, I think the MRCT Center has been introduced earlier, but our vision over our last 10 years of this organization has been to improve the integrity, safety, and rigor of global clinical trials. And we do this work by engaging diverse stakeholders from across the research ecosystem. And we really engage them to help us define what are the emerging issues that are facing individuals working in the clinical trial space, and how can we work to create and implement ethical, actionable, and practical solutions. And I always like to emphasize that last piece, because after spending many years in that sort of on-the-ground work as a research assistant, a research coordinator, an IRB analyst, reviewing protocols, and working to educate investigators on how to present their information to participants, the idea of practical and applicable in the workplace, you could start today and start doing some of these things, is really important to me. So on the next slide, I'll share with you a little bit what the MRCT's ongoing commitment to health literacy has been. Back in 2017, we released guidance on return of results, both aggregate and individual results, and that was in response to the EU mandate to provide plain language summaries to study participants in Europe. And that portal is coming for the EU studies. But what we learned in that work was that health literacy, clear communications, plain language, numeracy, design, all of these things need to be applied to those end of study result summaries. And surprise, all of those things need to be integrated, not just at the end of study, but all the way through the clinical trial life cycle. So it was in 2018 that I helped lead a group of about 50 work group members to complete a multi-stakeholder initiative that was focused on health literacy in the clinical research space. And many of those work group members are on this call here today. And I can't say hi to you all, but I see you and I'm so glad that you're here. We ended up launching together a website on health literacy and clinical research in 2019. And that URL is there for all of you who want to check out the resources there. But it's really a comprehensive foundational source of resources and information for sponsors, investigators, IRBs, and patients and participants, if interested, to see how we can integrate health literacy throughout the clinical trial lifecycle. Last year, with the COVID-19 pandemic onset, we also developed COVID-19 pamphlets to support understanding of clinical research, kind of like that baseline foundational information someone could be presented with when coming into a health center with COVID, or perhaps supporting a loved one from a distance who has been admitted with COVID and considering perhaps clinical trial participation. So it would be kind of that baseline primer before they might be approached about a specific research study related to COVID. And over the last couple of years, I've been spending a lot of time designing and delivering clinical research-focused health literacy trainings for different organizations and groups. On the next slide, you'll see that we also are committed to health literacy across the age spectrum. And so one of our larger recent projects is related to the inclusion of pediatric populations in clinical trials and the clinical research space. And so we have been developing a suite of resources, that were related to COVID. So if we had issues related to COVID trials, we had those for the pediatric population, but also just general introductory research information as well. And so you'll see in the center there a flyer that's been developed around assent to consent. When a minor comes of age, what are some of the things they need to think about if they want to continue on in a study that they started when they were under the age of majority and then transition to the age of majority. On the next slide, then I'll just note then what we started to think about in terms of a clinical research glossary. This health literacy work group that came together in 2018 and 2019 we kept sort of coming up upon the issue that we didn't really have a consistent, accurate, and simplified glossary of clinical research terms that were available for use across the research industry. And let me note, there are some wonderful glossaries out there, medical glossaries and specific disease area or therapeutic area glossaries, but not one that is specifically tailored to the clinical research space. And we really wanted to focus on harmonizing definitions across the industry because promotion of a unified approach would really help best support patients, participants, and their caregivers. Next slide, please. So when we came together in 2020 to pilot this glossary, I thought we could come together to develop a plain language clinical research glossary that includes definitions that are co-created with patients, a very important part of the work, designed for public understanding. So this would be an externally facing resource for the public, but also contain definitions and information that's acceptable to industry and academic stakeholders, so that this would be something that could be used by individuals across the clinical research ecosystem. And we wrote about that in a paper that you can link there on that hyperlink. And you'll notice then on the graph that what was key to this work as well is that we had large patient and patient advocate representation. So over a quarter of the group was comprised of individuals that represented patients with different health conditions, cancer status, neurological conditions. We had a teenager, a pediatric member, their mom, a young adult in college who had a hearing impairment. So we really had a wide array of patients and ages represented on the group, as well as many different groups from across the research ecosystem. Next slide, please. And then the approach to the pilot was really to use this agile methodology, this iterative process, where we selected initially just about 50 words. We ended up with 53 in the end, but 50 words that were from various participant-facing materials and resources. We then created plain language definitions and collected feedback from the work group to get their input on whether that plain language definition was working for them. And this was through a cloud-based process, Google Sheets, where I was collecting this data information and then trying to iterate on the definition. I'll say only a small number of words reached consensus via this Google Sheet approach. And so we ended up moving towards having consensus conversations via virtual meetings to finalize definitions. And these were these wonderfully rich, collaborative, collegial calls that I don't think I'm alone in saying these were, people really look forward to having them weekly and having this time together, and was a real highlight during the winter of the pandemic, which was a pretty dark time. We then moved on after we had these consensus definitions to create supplemental information. And I'll show you a little bit more of what that consists of in a few minutes. And then we finalized the website in preparation for our launch in June. And we had ongoing patient advocacy engagement and iterative usability testing built in throughout, so that really we were the elements of the template, the website, all these things were kind of being built around the same time as we were working on the definitions and getting feedback. So we were really building this out in real time and getting feedback along the way, which I really loved. Next slide, please. So some of the hallmarks of this were really, as I've noted, this co-development with patients and participants and this user testing with patients that we were able to engage in. The fact that we ended up with these primary plain language definition that people could find and easily focus on, but then also had additional use in context, additional resources, words, explanations that people could drill down to if they wanted to. So they could start broad with the plain language, but also move into more specific information if they wanted to, was really flexible. We also added associated images and graphics to support each of the terms in the glossary, and included an auditory pronunciation guide as well. In terms of dissemination, what's been really fun over the last few months is that with our interns over the summer, we developed a Word of the Week social media campaign that went out on Twitter and LinkedIn and is ongoing, that every week a new clinical research term is sent out to our social media audience. And that is something that others in this audience could do with words from our glossary, is to create kind of these tweets or LinkedIn posts or otherwise used in social media to normalize clinical research terms, make people familiar with research terms, and have this glossary accessible. They also recently shared the glossary on screens around our hospital system, and I'll show you what that looked like in just a second. But for Health Literacy Month, that's what we did this month. And we've also are planning and working towards deploying it in a clinical trial recruitment site that we're collaborating with. Next slide, please. So here you'll see what was on these computer screens around the hospital system here. We have a couple of hospitals served and multiple community health centers and different clinics and sites around the greater Boston area. And you'll see we actually made a URL that's a little shorter than usual. It was mrctcenter.org/clinical research glossary initially, but we changed it to glossary to make it easier to be seen on a screen. There's a QR code as well, if folks are getting more familiar now with our pandemic world with using QR codes to read menus and access different information. So this was something that we included as well. And this is really foundational, we think, to our mission as well at the MRCT Center, which is to provide this foundational information about clinical research in contexts where people are getting clinical care or in their communities, right? Before folks are approached about a particular study, wouldn't it be nice if our organizations were actually spending energy and doing these awareness campaigns around clinical research and helping our communities feel comfortable with the idea that research does happen here in this center or in our community? These are some of the ways that research may have benefited my community already. And here's some resources to help you get familiar and comfortable with research as a concept. That way, when people are being recruited to research studies, maybe down the road, they already have some exposure to what research is and maybe feel a little bit more comfortable in considering participation or recommending it to others. Next slide, please. So if you use that URL, it takes you to the site. Next slide, please. And then you'll see that we have just a high level view here of what a definition might look like. And I'm sorry if it's a little fuzzy. I think in the emailing, the images got compressed. So hopefully you can still see enough to note that we have the term, the plain language definition. Here's where the auditory pronunciation would be if you clicked on it. There's the image. And then, like I said, the additional information like use in a context, more info, and other resources. Like here we have an FDA resource. If you click next, please. This randomization image, again, just shows the way that we presented randomization. And in some instances, we created graphics ourselves to try to help explain that term. Next slide, please. So as we move forward, we are urging commitment to using common definitions across the research industry, and we're exploring expansion to the version 2 of this clinical research glossary, moving from this pilot proof of concept to something more sustainable and expansive. So we would add new words, add just-in-time terminology, perhaps of what's happening in the popular press and media to be able to help define maybe some critical terms that need to be defined in real time. Considerations for translation, of course, really important, and moving on from there. So thank you so much, and I look forward to hearing Barbara's presentation and the discussion.
Thank you so much, Sylvia. That was really, really great. So next we'll hear from Barbara Kress about the plain language clinical terms glossary that Merck's working on. Ms. Kress is the Executive Director of Clinical Data Disclosure and Transparency at Merck, where she's responsible for registry and results disclosures, redaction operations, return of plain language summaries to patients, and data sharing. She's been working in the transparency space for about 15 years. Ms. Kress, we're really looking forward to hearing what you have to say.
Thanks so much, everyone, and good afternoon. Today I'll be talking about a new initiative within my department, and that was creating a health literacy glossary. Next slide. Right. So what is health literacy? Before working at Merck, I was an ER trauma critical care nurse. And along with all the nursing responsibilities in these settings, I also served as a translator, right? And it's not the translation you might be thinking of, which is perhaps English to Spanish, which indeed I did have to do. But I translated the medical language to basic English for patients, their families, and their caregivers. And this was and is a critical component of the job. An individual cannot make important informed decisions without understanding the content before them. Health literacy is that ability. Next slide. So why is it so important? Well, it's about control, choice, collaboration, and consequences, right? It allows patients to take control of their own well-being by making informed choices that are discussed collaboratively with their healthcare team to avoid negative health consequences. And as an ER nurse, I can tell you that many patients didn't use the ER appropriately, right? They're better served at the clinic or by their physician, but they see the ER as the easiest access point. Well, health literacy helps patients and their caregivers understand how to use services available and the best way to access them, how to manage chronic condition using up-to-date information that they can act on. It also helps them navigate the health system itself. And I think we could all use a little bit of help with that. Next slide. So pharma communicates with patients in many, many ways. And pharma has many touch points with the patients, families, and caregivers. And before approval of a medicine and before a trial even starts, recruitment materials are prepared. And these are made public. The informed consent document is extremely important, and it contains a wealth of information about the trial and the medications administered. During the trial, there might be updates communicated to the trial participant about how the trial is progressing, how the participant is progressing or not. And at the end of the trial, you might get a summary of trial results, right? Then there are patient-reported outcomes, labeling, packaging, and consumer ads. These numerous important touch points with patients provide an opportunity to utilize health literacy as a guiding principle so participants and patients can control, choose, and collaborate. You can go to that post-approval there. Yep. Next slide. So why did we develop a glossary? Well, the short answer is that when we looked externally for a health literacy glossary, we didn't find much, like Sylvia said. So we decided to make one on our own. The longer story is that my department is now responsible for authoring plain language summaries. And these PLS documents are summaries of the overall trial results, right? And they must be written at a middle school reading level, and they'll be required under regulation in the EU in 2022 and in the UK as well. When the team started to pilot the authoring of the PLS, they found that a lot of time was spent looking up medical terms and trying to make them easier to comprehend, to fit into a middle school reading level, if you will. It became clear that asking highly skilled, seasoned medical writers to author in plain language was not an easy task, right? We have a health literacy team at Merck, and we reached out to them for some help. And they put us in touch with Health Literacy Media. And HLM was instrumental in training the staff in health literate principles, but we were still lacking in term and definition consistency and efficiency. It was still taking too long to produce these PLSs. So the team started to work on a few medical terms that they identified consistently in some of our documents, and they started compiling a list. And that list turned into a 1,000-word glossary today that includes terms and definitions. So Merck now has a health literate glossary to utilize along the life cycle of a trial and all of its patient or participant touch points. Next slide. So this all started in July of 2019. The team used common adverse event terms from results disclosures, the informed consent, risk language, and labeling. And the team enlisted medical reviewers. These were physicians at the company who were able to review the terms and definitions for accuracy. The glossary was piloted across 10 groups, and feedback was, of course, collected. And just recently, we did a cultural competency review through the Employee Business Resource Group and the Merck Nurses Network. And the glossary was launched in October in celebration of Health Literacy Month. Next slide. So challenges. When you develop something new without a prescribed template, certainly there are many challenges. The team reached out to many different areas of the company to try to align terms or already existing health literate materials that were being used. There was a wide range of reaction from people not having enough bandwidth to provide the terms or pilot or offer feedback, to others who wanted to do so much more with the glossary than we were actually ready for at the time. And we had difficulty finding materials that HLM reviewed for us in the past. So that prompted work on a repository to store all of our information related to health literacy. We had to keep all reviews internally. We couldn't use external groups. That's where those cultural competency reviews came in, and they were very eye-opening for the team. I can give you an example of the definition that we used for HPV accounted for cervical cancer only, while the LGBTQ representative reminded the team that it's not only for cervixes, right? There's a lot of other things that happen with HPV. So the feedback helped the development and review of definitions for new terms. And these reviews really engaged the employees, showed them that their contributions were valuable and that they could impact patients' lives. We're struggling with the graphic development. Graphics are a huge and important part of health literacy. We're not artists by trade, and how to tackle this, I think, is one of our biggest concerns as we move forward. Next slide. So considerations for 2022 include translation. This, I think, is our most requested application of the glossary. We're aiming to expand the glossary within the company to medical devices, packaging and instructions, and we will be collaborating with MRCT on some glossary terms. Thank you.
Well, thank you. It's incredible to hear two examples of how people are creating glossaries and thinking about terms. So now we have a few minutes for a Q&A for our speakers. So I have a couple of questions that have come in from the group and also some questions that we prepared in advance. So I'm going to start with one that came in from the group, just that's really basic. It'll only probably take a second, but Barb, someone asked if you use the MEDRA codes, the patient glossary and the codes for technical terms there when you were beginning this developmental process. You're on mute.
Yeah. Oh, sorry. Yes, that was something that the team did take a look at.
Okay. And then one more quick, just sort of technical question. And what did you apply the glossary to patient-centered information posted as part of the registrations to ct.gov?
So that's my next big challenge, is to try to do that for clinicaltrials.gov as well as UDRA-CT when the new regulation comes into. That's really one of my goals for 2022.
Fantastic. So now I have a more broad question for both of you. Those were really fantastic talks. And as I mentioned, great examples of how people might put this in place and either use an existing public facing document or work on something internally that's really reflective of a sort of culturally appropriate internal set of materials. But I would love for you both to talk for just a moment about any strategies you've used to really engage those multicultural audiences in the tools. You talked a little bit about development, but more about implementation and sort of where you are with that.
Yeah, so I'll take that first. I think I hit a little bit on that in the talk with the cultural competency and the nurses network. These are really great aspects within Merck that we can utilize these groups. And I think my team would tell you that it was a really, really great experience to understand that some terms that we just think of as self-explanatory really are not. And Barbara brought up a great point about trial, right? That was brought up for us as well too, as being something where you go to jail, right? Or using the word drug in a different language, it has a connotation of being an illicit drug that you buy on a street corner. So that also comes in with the translation aspect to this, which I think really brings a heightened element to this that we really have to be careful about.
Mm-hmm. Yeah, and in terms of implementation for us, I mean, as I noted, we, as a small pilot with our small work group, we were able to have a broad representation in this piloting process and would want to seek to expand diversity and representation in any expansion efforts. But even just this example of putting it into these screens around the hospital, like that seems like a very small thing, but our hospital system has priority neighborhoods that are home to many of Boston's communities of color, and our patient population is approximately 50% representative of communities of color. So we're able, through a simple, pretty simple thing of this on the screens, at least starts to normalize in terms of implementation. These words are being shared. We're talking about clinical research in this hospital setting or in this community health center, and we can hopefully from there expand to having more detailed conversations and outreach about research. So I think culture is such a broad concept, and we can kind of think about from language and race, ethnicity, but even patient groups or particular diagnoses create like a culture around that. And so we can kind of avail ourselves of these different patient advocacy organizations and the relationships we build with others to get input along the way to iteratively continue to make our resource more applicable and widely available.
I really like the way that you're talking about that as an iterative process. Both of you are sort of mentioning the steps in this, and very specifically for something that's as big as a glossary that would define all the terms that people use in this context. It's going to change over time, and it needs that input. So it's great that you're thinking of it that way. I have, I think, time for one more question. This one is really fun, though. Do you have examples of times that feedback from a particular community has changed the direction you were going with the tool? Have you had times when you really learned something that surprised you and it made you think about it differently?
Sylvia, you can take that one first.
Sure. I think one of the things that was really fascinating in our pilot process was that we had, as I mentioned, one person who is hearing impaired. So even in our process, thinking about our Zoom world and having captioning and then adding this auditory pronunciation guide, which is also really helpful for folks who may not speak English as their native language and are learning pronunciation for things. So that didn't so much surprise me as it was like, almost like a no-brainer. Like, why aren't we doing this more? Like, these are things that we need to think about to be more inclusive. And so it was kind of fun to be able to be like, oh, we can add that. We can make our meetings closed captioned and help people out. I've made things bigger in terms of our Google spreadsheet for our person with Parkinson's who had a hard time being able to navigate that spreadsheet. Like, we can iteratively adapt our processes, both in developing things and the way we roll things out to accommodate a wide variety of people and abilities. So this was just an exercise in that, and we can continue to grow from there.
I think that's really a story of health literacy at times, though. Sometimes that you hear something that is so much of a sort of duh, that it's so true. And it's like, how did we not think of this? How are we not working on this already? Of course, we're going to do that. Of course. So it's so nice when you have those experiences.
Yeah, so from the Merck perspective, I think, we're so basic right now with what we've done with just amassing the 1,000 terms. I think we have so many more places to go with it. And the pronunciation issue, I think, is huge for us. And, that's why we're going to be partnering with MRCT, because we really like what they're doing with the website. Ours is very basic, and we need to push it up a little bit more and make it a little bit better and bolster it that way.
We have mutual admiration for each other because you have so many words.
Yes.
We've got a bit more of a I guess, a presentation, but we're going to merge forces to be Power Glossary.
Exactly.
All right. Well, thank you both for your time. And it's then now my pleasure to hand off to the co-moderators of the next session, my colleagues Amanda Wilson and Silas Buchanan. Ms. Wilson is the Chief of the Office of Engagement and Training at the National Library of Medicine, where she works to distribute biomedical and health information resources and data, improve health literacy, and advance health equity through information. Mr. Buchanan is an experienced engagement strategist in underserved community outreach, including within the arena of clinical trials. He is the founding CEO for the Institute of eHealth Equity and co-developer of the AMEChealth.org, the official health information sharing channel for the African Methodist Episcopal Church. So I'll hand it off to you.
Thank you very much, Dr. O'Leary, for the introduction. And hello, everyone. We're really looking forward to hearing from our speakers on this last panel, integrating clinical research information into care and community settings. This panel will be focusing on identifying some tactics and strategies for engaging the community around clinical research, and we'll discuss what role health literacy might play in those strategies. Rather than having us, the co-moderators, do full introductions for each of our 4 panelists, we're instead going to give them each a chance to take about 3 to 4 minutes to introduce themselves, their work, and how it connects to this topic. After that, we'll go straight into the moderated discussion, which will take us through the end of the workshop. We know we already have a few questions in mind for this group, and we're seeing in the Q&A that there are other questions that we can ask as well. So please remember to submit questions through the Q&A as you're hearing the discussion and the introduction. So let's get started with those. I'll ask that Dr. Michael Pash-Orlow, Professor of Medicine in the Department of General Internal Medicine at the Boston University School of Medicine and Boston Medical Center, introduce himself.
I thank you very much. I'm really happy to be talking about this topic and with you all about this. So I mostly do health literacy research. I'm a general internist. I see patients at BMC, but most of my time is for research. Really been blessed in this space. Have 19 currently funded, federally funded studies currently. Most of them are in health literacy, but actually some of them are in clinical trials. Since COVID, we've jumped into drug trials and with a very, very significant focus on health literacy, but also on diversity, equity, and inclusion. I'm the inclusion lead for the Massachusetts SEAL network. Some people may be familiar with the SEAL initiative out of NIH. And 21 states have initiatives now to promote diversity, equity, and inclusion in clinical trials. And so I'm proud to be the inclusive participation lead for the state of Massachusetts for the SEAL network. Anyway, that's enough for now. I'll go on mute.
Thank you, Michael. Next, let's move on to Ms. Monique Hill, Program Manager for Hands on Health.
Thank you, Amanda. Yes, I'm Monique Hill. I'm located here on the coast of South Carolina with the Medical University of South Carolina. I have been program manager of one of our community outreach health literacy projects for about 11 years now. And so the majority of my work in health literacy has been based on the community side, and also in terms of developing coursework and trainings and seminars for health literacy for our clinicians and students. My work in health literacy originally started, I tell this story now so I don't have to tell it later, but part of who I am and why I do what I do is because I was personal experience with health literacy long before I even knew what the term health literacy meant. So I'm informed by not only my personal experiences, but I also like to think that this work that I was thrust into essentially is a purpose-driven line of work for me. So I'm also serving in the capacity as health literacy advisor and partner strategist for the regional medical library that is housed at the MUSC libraries as well. So glad to be here and looking forward to the discussion.
Thank you very much, Monique. Our last introduction at this time is Dr. Rebecca Engel, who is the Vice President of Patient Experience and Program Evaluation at the Patient Advocate Foundation.
Hey, good afternoon, everybody. So I'm really excited about this panel and this conversation. Little bit of background about me and my organization. So my expertise and really my formal training is in integrating the patient voice into research policy and health system transformation. I have a PhD from the Medical College of Wisconsin, so I've always been kind of front and center in working with patients, but that training was also in community-based participatory research. So, you know, my public health lens, my CVPR lens, and then my medical lens really brought me to where I am today. I did start my career coordinating drug and device trials at a major academic medical center. Then I served as engagement director for a PCORNet clinical research network. And I have and still do serve as PI on a number of PCORI and RWJF projects focused on integrating the patient, the community, and the provider voice into research. So, you know, I kind of explain my expertise in my world as I'm an engagement methodologist at heart. At PAF, it's really exciting. I got to connect with patients even closer. So we at PAF help patients facing access and affordability challenges. We serve over 120,000 underserved and under-resourced patients a year. Patients are economically, racially, and geographically diverse. And so in addition to the direct services that PAF provides, I actually am the leader of efforts to learn from these patients about their experiences, their perspectives, amplify their voice, because most of these patients have been historically underrepresented in clinical and health research, and have, you know, challenges in health literacy and research literacy. And then we at PAF partner with a number of clinical and academic researchers to initiate you know, patient-driven research. And we also do a number of internal survey and data projects specifically focused on patients' willingness, ability, and confidence to engage, not only in healthcare, but also in research projects. So I'm excited to kind of bring that whole constellation of experience to this group and be part of such a dynamic panel. Thanks for inviting me.
Thank you very much, Rebecca, and thanks to all of our panelists for bringing your expertise and experience to this discussion. Your backgrounds have provided a rich context from which we can explore the topic of how adoption of health literacy best practices can enhance clinical research. I want to again encourage everyone participating to use the Q&A to submit questions or comments for one or more of our panelists. Since this is a large topic, there are three kind of themes or buckets that we definitely want to cover, in addition to what questions that come from the audience. Those three themes are community engagement strategies around clinical research, so implementation experiences, opportunities, and challenges. They're how clinical research might intersect with other literacies, for example, digital literacy or research literacy and numeracy, and how these all flow back into improving health literacy. And third, concept of organizational health literacy, which I think Dr. Vera did a great job setting up the session with that. So that's how the research system might meet patients or partners where they are in terms of health literacy. Before we move on, I'd like to ask Dr. Kareem Watson to please introduce himself, welcome, and give us a little bit about your background and how your background relates to the topic of the workshop today.
Good afternoon. Thank you. My name is Kareem Watson. I'm the new Chief Engagement Officer for the NIH All of Us Research Program. I'm trained as a community health scientist with a research background in cancer prevention and control, particularly from the point of community-based participatory research. Prior to joining the NIH All of Us Research Program, all of my research was community-centric and involved community stakeholders with the focus on diversity and equity in clinical trials. And I often call it a dual purpose focus on diversity, equity, and clinical trials, focused on inclusion and making sure that those populations that have been historically underrepresented in research are included in all aspects of research from design to implementation, but also with a focus on researchers that are historically underrepresented in research. Because what we know and what we've learned, even from the literature, is that representation matters. And there's a richness when we can ask questions, when those that are asking the questions, the research questions, also carry the lived experience of those populations that we're often researching and asking the question for. And lastly, I like to say that I like to think that I do research with communities and for communities instead of research on communities. So thank you for having me today.
And we'll hand it over to my collaborator, Sayo.
Well said. Well said. Can you guys hear me okay? Good? Okay, great. Awesome. Thank you. Amanda, thank you very much. I'm thrilled to co-moderate this panel with her. And I'm sure I speak for Amanda as well as our audience as I share how excited we are to engage and, more importantly, learn from our fabulous panel today. I know a little bit about each one of our panelists from previous engagements or experience, and they're absolutely second to none in this subject matter. Throughout our conversation today, we will, and I think Barbara teed this up for us just a little bit earlier, and it's been a bit of a running theme throughout some of the other panels, and then Kareem just touched on it as well. But throughout the conversation today, we'll weave in some emphasis across our themes, the themes that Amanda shared, on understanding tactics and strategies for engaging communities of color and underserved communities of any color, both urban and rural, to improve how we more equitably integrate the clinical research information in both care and community settings. Diversity, equity, inclusion, and accessibility. And that accessibility piece is very important as well for folks that have a disability, is currently receiving unprecedented levels of positive attention by government, academic, and healthcare stakeholders, inclusive of clinical researchers. And this current diversity, equity, inclusion, and accessibility focus and the burgeoning collective energy and resources emerging around it are quite significant. And if harnessed properly, could benefit clinical researchers and also the health outcomes of underserved community members that have experienced many years, as we know, of poorly addressed disparities in health and healthcare, which in turn has fostered some distrust of the healthcare system writ large and the clinical trial enterprise and research enterprise specifically. So it's with that in mind that perhaps we'll start our discussion today with a question about the role of trust or lack thereof in underserved communities and how it impacts the integration of clinical research information into the care and community settings and how it impacts the work of our panelists. So I'll tee up a first question for our panelists, and any or all of our panelists can weigh in here. We know that leaders of community-facing organizations, inclusive of faith-based organizations and library staff as well, are many times known, liked, loved, and trusted by community members. Clinical researchers, however, many times, not so much. So the question is, how do you, as panelists, how do you currently, or how are you planning to leverage the trust that these community leaders have to more effectively partner with them and or even train them to lead conversations and share information about clinical research?
I'll start off if it's okay. One of the ways, I'll give you two brief examples of how we've leveraged community-based partnerships and that trust. Sometimes I call it trust by proxy. And I'll tell you one way that I've done it in my previous research. One of the projects that I've done was a tool around engaging African-American men as citizen scientists. There was this concept and belief that I did not agree with, that African-American men were hard to reach for enrollment and engagement in clinical trials. I tend not to believe that populations are hard to reach. I believe that we're just not in the populations where we're not in the places and spaces where those populations are. And so this concept of hard to reach African-American men as the reason for why Black men were often not included in biomarker screening studies, we tried to dismantle that by leveraging the trust of African-American men as citizen scientists. So we use a social network theory There was 3 principal investigators, myself, an African-American urologist, and another leader of a community-based organization. That's one best practice already, is having the community-based organization as part of the leadership team. We use social network theory to recruit a group of trusted experts from our own social networks that included pastors, fraternity leaders, and other African-American men in the community that were trusted messengers. And we adapted a citizen scientist curriculum to engage those men and train those men as citizen scientists so they could then go out and help us engage their social networks. So we leveraged the trusted message that they already are. And we ended up really exceeding our recruitment goals and actually meeting our recruitment goals early to engage African-American men in a prostate cancer screening biomarker study. And in my current work, the way that we're doing that is that we actually provide grant awards to community-based organizations, including faith-based partners that have trusted and national reach. The National Baptist Association is one of them. We know that they're one of the largest faith-based associations that exists in the country. So by providing them the resources that they need to promote the tenets of the NIH All of Us research program, we know that that trust is already engaged, and we still have to build relationships, but we start off with a trusted messenger and resourcing that messenger up appropriately.
Yeah, that's significant. You know, Rebecca, if you would touch on that, maybe from the social service agency perspective, because I know you guys do work sometimes fairly intimately with social service agencies, right? So would you just kind of, address that same question, but think about how you might engage, community leaders or community members through social service agencies?
Yeah, absolutely. The one piece I want to add before answering your direct question is the how you frame these things is really, really important. Putting the burden on patients or communities to trust you can feel a little one-sided. So I think everybody should start with the kind of looking at yourself as an organization or a researcher and saying, am I being trustworthy? Am I demonstrating trustworthiness? And then, moving out into relationships. I think Kareem, touched on one of the tenets that we really found as a cornerstone to building trust in communities and with patients is bringing them the services and the resources that they need, right? And so for a lot of our work at PAF, we actually, it's a great organization to work for and with because we have the ability to provide direct services for patients that are facing access and affordability issues. Through that, we're helping patients, we're helping communities, we're building that trust, bringing communities and patients what they need. And then we can then go and ask them, can you, be part of this project with us? Can you partner in research? And I think that's the other piece that I would add. Our first ask is never, can I enroll you in a clinical trial? Right. The first ask is, can you help us identify and engage with us and be a, co-PI, be an advisor on these projects? So we are focusing on what is most important to you, what's most important to your community. And so we do it together. Then that enrollment becomes much more natural, right? So you're not going in, and the first ask is never, can you enroll in this trial? The first ask truly should be, how can we help you? And what is important to you that we can study together? So that would be my recommendation for organizations. And we do that in partnership with other nonprofits. We do that in partnership with social service professionals, whether those are community embedded or social service workers in a clinical setting.
That's awesome. Amanda, can I follow up?
I want to add a comment to that because I feel like the space and this conversation that we're having about trust is really the root of the problem, but also the solution in terms of how we use and define trust. And so I wanted to kind of follow up with Rebecca in terms of why are our community members not trusting our researchers, or what are we doing to cause our community members to not perceive us as not being trustworthy? And I think it's in most of these cases, when we need our community is when we go to the community. And so in in terms of figuring out a way how to work through the community instead of going to the community and asking them when we need them. How do we engage our communities, our CBOs, our faith-based organizations in this clinical research space prior to a need of enrolling anyone in our trials? I think a good example of a colleague who worked with me here at MUSC through the Hollings Cancer Center, she spent 7 or 8 years building what she called the Community Compass Project. And Community Compass, the name was selected because Community Compass was the community navigated and told us the direction of what they needed and what they wanted. But us as the institution, the medical university, and the cancer center, we provided the resources that the community need. And so this was an annual ongoing project where community was engaged throughout the year. We got feedback. They informed us of their projects. But when it was time for us to ask them to join us in whether it was research or any other community program, they were willing to do so because we had a relationship, and you can't have trust when there is no relationship. So I think in this conversation, we have to acknowledge that also, that we tend to move into the community when there's a need.
If I might, I strongly agree with each of your comments here. I just want to make something a little sharper and also bring it back a little bit to the overarching theme today, which is anytime someone's talking about trust, it's very, very othering, and it's very, very pointing the finger. And so it's really important to get at this issue of, like, what does it look like for us to be trustworthy? And I think health literacy is part of the solution. I mean, I think that's part of what we can do. 9-point font is not trustworthy. You know, it would be callous and cynical to not care about these words that we're using in these consent forms. But consent forms, the whole thing, it's just not trustworthy. Like, it has to start with relationships that people actually feel comfortable with, and people were getting at all this stuff. Anyway, I think health literacy can be part of the solution towards this, but it's going to include other things too.
Without a doubt, the messenger many times is more important than the message, and so you've got to make sure that the messengers, right, are armed with the right tools and the right words, so that they can impart the knowledge, right, in a way that will be more well received by targeted community members. And I think that's critically important. Just as a quick follow-up question to that, and I think Kareem touched on it a little bit, but I want to hear from each one of you guys on this one. From your perspective, does the infrastructure exist? Right? Amanda and I were talking last night. We were talking baseball, right? We were talking about Braves and we were talking about the Astros. And we're talking about pitching and we're talking about catching. And you may have a pitcher that can throw 100 miles an hour, but if you don't have a catcher that can catch that 100-mile-per-hour fastball, you're going to have a problem as a team. So the question is, from your perspective, does the infrastructure exist for community leaders to learn themselves, to be trained to receive the messaging as trusted messengers, to then impart that knowledge to improve health literacy in their own communities, right? Because you can try and recruit all you want, but if they can't equitably receive the message to impart it, we're not going to get there. So if you guys could just touch on that a little bit, some of the structures or infrastructure that may be in place. Kareem touched on some of it already, but I'd love to hear from all of you guys on that.
Yeah, maybe I can jump in here first. So I led a project a couple of years back establishing community research cafes where we would bring community members together. There was kind of a structured conversation around really increasing research literacy. And I think more importantly, just normalizing conversations within communities about what is researcher, both amongst community members and leaders, but also amongst researchers. So I think there are increasingly a number of programs similar to that one where there are spaces and places and people in place to have these conversations. I think as a kind of field, researchers, and when we think about health literacy, I think we need to pull back a little from the idea of we just need to educate people, right? So I come from a public health background, and we have learned year after year after year, education usually isn't the problem, or if it is, it's not the only gap, right? There's a lot of other things, confidence, motivation, that affect behavior. And so I think structurally we're in a really good place to have those conversations and teach, but I think that relationship piece is what we really need to strengthen the ability to have relationships and the spaces to create those relationships. So I would start us there. I have lots of other thoughts, but that's where I think I could start us.
Rebecca, I'll add on to that. And I think even give an example that goes back to you all. When I think about what happened, Silas, during the pandemic to when I was at the University of Illinois in Chicago, the Cancer Center, prior to my previous role, during the pandemic, many of us had to pivot to address basic needs of our patients. We didn't have the luxury of asking about, do you want to participate in a clinical trial, while at the same time thinking about your food that you may need to get through your cancer care treatment. It was a partnership that we had actually built through PAF that allowed us to maintain the trust of our participants and our patients, and say that we value you as the whole person. And yes, your cancer survivor journey is important, but your basic needs are important right now. And it was through resources from a partnership with PAF that allowed us to get some of those resources in the hand of our patients. But from a systems perspective, you talked about, there was a structure that we took years to put in place that would allow us to provide patients the direct resources they needed. It was a grant from PCORI that we got for patient engagement that allowed us to really examine and sometimes dismantle the system that existed, that sometimes prevented the resources from getting to the various populations that needed them the most. And the last thing I'll say is about health literacy, to kind of go back to something we said before. One of the things my citizen scientists often taught me was that we don't talk about health literacy in this bidirectional way. They would say, Kareem, you always want us to learn to speak your health language, but how often do you train your providers in your health system to speak our language? We have a certain literacy around navigating our diseases and our care. We've been doing it for a while, but you all don't know how to speak our language. But the onus is always on us, them as the patient and the community, to learn to speak the academic language instead of the other way around. So,
yeah, well said. That's exactly right.
Just to expand, keep on going with, Kareem, you're pointing out how it's got to be bidirectional. I would actually expand farther that when we think about literacy, what are we even talking about? So there's different literacies, and effectively, when it comes down to it, it's actually having power to do things. And if you're not actually thinking about how does power work in these relationships, or how does power work in these organizations, then you're not actually talking yet about what literacy means. Your power to understand how to use a computer, or to do any of these different things, it's just a competence and power. So it's not about words, it's about power and social capital. So who has the capital to ask questions and make demands of a system? And so if you're not thinking about how does power work in the relationships, then you're not really getting at who can. You're not going to be able to empower people, and that's part of what's going on here.
Those discussions, I'm going to shoot it over to Amanda, but those discussions, Michael, they tend not to happen publicly. There's conversations that happen, privately amongst like-minded, stakeholders, whether there's a group of pastors or it's a group of barbers or beauticians. But as soon as the doors are opened to healthcare providers or researchers, some of those conversations, they seem to lose some of their steam and focus. And so having those transparent discussions about where power lies, marginalization and mistrust, and the history of that and how that impacts us today, it needs to be part of the conversation all the time. Amanda, please.
Yeah, and I was just going to jump in too, because I think a previous speaker highlighted that definition of health literacy, right? And we always think about the understand basic health information, but before that comes the capacity to obtain and process, right? So obtain means access. So that's the power you're speaking to a bit, Michael. And I think, the ability to process really is that kind of psychosocial, emotional, are my needs being met? Do I, trust this individual, this entity? So I think those are all dimensions. And you're right, we do get hung up on literacy as a single, do you understand the words I'm saying? And it's much more. So we need to look at that entire definition that was presented, I think, in our last panel.
There was a question in the Q&A that I wanted to bring up that I thought was kind of at the nexus of trust and health literacy. And that is, how do you deal with disinformation that some patients may see in social media or on media?
Amanda, I'll speak to that one because that's one that I always like to talk about, because we're living in an era of main media really being social media versus what our traditional media has been. And so most of our information is being disseminated via social media. And so when you're trying to combat that, it's almost impossible because there's so much misinformation. And so when our communities and individuals don't really understand how to filter through and determine what's reliable and what's not, I think that's where the issue becomes larger than it really is. One of the things that we have worked on many projects for many years is not only training communities in health literacy in terms of understanding what this information is and how you apply it to your health and to improve your health and make those informed health decisions, but also how to identify when information is not reliable. And so I think that type of kind of sorting through how to combat that starts with a population that is born into social media, but also making sure that information that is inaccurate, that's being widely disseminated on social media, that we're combating that in a way that we're addressing what the facts are, but also making sure that we're staying consistent on messaging. Because when you have misinformation and then you have the valid information that is in fact the information that our communities need, if they don't know how to discern which is the best information, then we're at square one again. So I guess to really sum up the point that I'm trying to make is we have to also figure out a way to continue to disseminate good information, but also how to train our communities and individuals on how to identify what is not.
And if I may, Silas, just briefly, I think another piece to that is that one of the question asked about tools and tactics to ensure that we know how to best utilize social media. One of the things that we have to understand is that communities are already having these conversations. And I think Michael talked about this concept of power and structure. Conversations are already being had, and there's sometimes a bias in academia or industry where we think the conversations are not being had because we're not a part of them. But community members are talking, they're having these conversations. There are some trusted messengers and some influencers already out there, whether they be social media or other venues. One of the ways, the tactics that we've used is to do listening sessions and find out, if we sometimes just say, we want to assume that these conversations are already taking place around the COVID-19 vaccine and town hall forum. How can we better resource you up so that you can provide the information that you need to the people that you're already talking to, as opposed to us leading the town hall forum? Maybe it's for us to provide technical support. Maybe it's for us to provide subject matter experts to the leaders of those organizations that are already having the conversations, so that when they get out in front of the communities that they're stakeholders with, we can know that they're getting out with evidence-based information. We don't have to be the ones out front getting out, but empowering those and giving those that are already out front having the conversation evidence-based information.
Just to pick up on this, I think it's super easy for clinicians to get into a scenario where they're like wagging their finger with like the information they think is the information, and they don't realize that they are actually not providing a source of power for this person. A piece of paper is never going to be the answer, even though like it would be cynical to not make that piece of paper good. It's never actually going to be the solution. We did a thing at Boston Medical Center where, because we knew we had a lot of work to do on this issue, we held something called Restorative Justice Circles. So we created many people. It sounds like some people are familiar with this model. Yes, and it was one version of this. We did it a few times. One version of this was 40 African Americans from Boston who had said no to vaccine, and 3 health providers. I had the privilege to be one, and then we broke into rooms, and we spent 6 hours together in this version of it. We did it a few different times in this version. So the main question was experiences of racism in healthcare and how this influenced your decision about the vaccine and effectively to not get it. And it was very painful for me. It was very enlightening for me. And it absolutely changed the way I approached talking to people about this. Absolutely. And it really helped me become an emissary to my colleagues and also in our community projects about how to not be like all this finger waggy stuff, because it's not helping. It's not meeting where people are at. It's not empowering. And it was wrongheaded. So I think there are a lot of things, Kareem, I think a few times now you brought up basically trust by proxy, which is another, came up again in your last comment. I agree, but we also have to help people pass their, I have the knowledge and now I'm going to share the knowledge and then you're going to do it, that kind of approach is just not working.
I think too, I feel, a little tear down the ivory tower kind of vibe here, but I think we also need to think about what is accessible to people, right? To communities. They don't always need somebody to share that. We could do things like taking away paywalls for studies that are disseminated, right? Like there's a lot of barriers to getting information. And so what happens, going back to Monique's point about seeing things on social media, people are reading headlines, maybe they're clicking it and they're getting somebody else's interpretation of a study, which may or may not be correct, right? So when you think about clinical trial and people's interpretations and where they're getting their information, we can open up these spaces that have, historically been closed to anybody outside of the ivory tower, right? Outside the inner circle. We could pull down paywalls or even have, lay abstracts available. There are ways that we can do it so communities and people aren't so reliant on, people like us in this room to bring them information as subject matter experts all the time, because for the most part, the communities and the people we're talking about, there are our family members, our loved ones, our, lawyer, my daughter's teacher, right? They're not this other community. It's the people we interact with every day, and they're fully capable of understanding a lot of this information if we just give them access to the spaces and the information that's out there. So I think that's one actionable place that, as an industry, we can move that culture to more transparency and less, you have to somehow have an MD or a PhD after your name to even participate.
Yeah, I hear you guys, and part of what I hear is, there needs to be a mechanism to co-create campaigns, with community leaders, right? We don't just need to. I can't tell you how many church basements I've been in where someone from the healthcare enterprise has dropped off some flyers and said, "Hey, can you stick this in the church bulletin on Sunday?" And people just kind of put it right in the trash after they walk out the door. It wasn't from the community, it wasn't really representative, and they will look at it and say, this is wrong, this is wrong, and this is wrong. But that's after the fact, and there aren't these mechanisms, and that was the genesis of the question earlier about infrastructure that exists, basically to kind of co-create these sorts of things with community on a consistent basis. So a methodological approach to community engagement begins to emerge that can be replicable, right? Locally, regionally, and nationally. That's kind of what I'm looking to hear. And I think Amanda and I, as we had some conversation last night, we're certainly looking to hear for those approaches and where technology fits. And we can jump into some of that as well.
Just in response to that comment, I think what is often missing, especially when you think about clinical researchers coming into communities or engaging with patient communities, they're very quick to explain why they need to recruit why they need the patients, why they need the communities. They're less forthcoming around why this is valuable and deserves the attention of the person they're speaking to or the community. And we find that at PAF, a lot of times our messaging right now around some of our initiatives are not necessarily, we need you, but the idea that without your help, this is what's going to happen, right? We are going to exacerbate health inequities and disparities. We are going to create solutions that don't include your community and your perspective. And helping us is actually going to help your community. Those are the messages that we don't see a lot. It's easy for a researcher to come in and say, we need your community because we need more diversified recruitment. That's not going to get anybody to sign up for a trial, regardless of how informed and educated they are about that trial, right? So it goes kind of deeper and more foundational to even the health literacy piece, but to how and why you're crafting that message.
I absolutely agree. Actually, I even just to stand back and say, have we communicated how and what the goals of research are? Like, have we explained that this is for a public good? Your tax money is going to this, that this is actually is going, you know, that we have a project just to bring it to a more specific type of a thing. I have a project going right now in development with medical interpreters, because I realized that no one had ever talked with them about why we do research and what it's for and how it's a public good and why we think it's important to have diversity and inclusion in research. And, you know, their vibe absolutely comes across, you know, when we're working with them. And I would say it's not just the interpreters, all the staff, the doctors and nurses who are not a part of this enterprise. Do they understand why we care about diversity in this context? Or do they think this is just companies trying to make a lot of money? You know, like, and if that's the vibe that they feel, then we haven't really done the work. That's kind of the background work.
And I want to add to that, Michael, because I was thinking as I was listening to you also, you know, those who are in the study coordinator roles for trials, and, you know, might there be an opportunity there, or there may be curriculums and programs now that exist to train those coordinators in health literacy and appropriate communication strategies that we are not seeing now. And, you know, a prime example of this is I recently received 3 different messages relating to a study. So I received it twice via text message and once via email. None of those messages really shared with me the same points that you and Rebecca just shared, you know, what the benefit is for me. It was an ask. And it was also a bit strange because it was just a random study that I may qualify for, but it was because they had linked it to my medical chart, I believe. So I opted in. But I just wondered if I were not as involved in a medical system and understood clinical trials, research studies, would that be an appropriate way to communicate an interest in the trial? And I don't think so, because anyone else receiving that same message, it would send up a red flag, because this particular trial is related to use of alcohol, and it is very intrusive if a person doesn't really understand what the intent of it is for, and also how you obtain my information. So I think 2 points with that story is, number one, we need to be training our study coordinators in how to communicate in a way that's going to be relevant and better received to those that we're recruiting into these studies. And then also taking a step back to look at the fact that not only do we have a lot of data that patients are now entitled to, we can see these charts, there's a lot connected to your personal medical records, but also keeping in mind that a lot of our patients don't understand what that information and data is used for, and also how they can use it and how it's connected to all of their care beyond just medical care, but also in terms of clinical trial recruitment. I think every level of those clinical trials, we really have to make sure that we're educating, and it starts before recruitment with our study coordinators.
I think you're absolutely right to point to the study coordinators as part of the solution here, or like an area for improvement and growth. And I think health literacy principles can help in this area too. It's kind of easy, or it's reasonable to have a glossary, but the glossary is really for the writers of these documents. And the documents then go to the IRB and this and that and the other thing. And ultimately, it's going to be transmitted through the coordinators, through the research team, not by the PI. The PIs are mostly absentee landlords on these problems. They're actually typically not involved in the actual interactions with the participants in any substantive, meaningful way. And one of the special things that will have to happen, for these glossary programs to even have is to transmit the cultural motivation of succeeding with communication to the coordinators, that they actually would have the training and the skills and the time and succeed in proving that people understand substantively what they're getting involved with. And in any case, we also shouldn't spend so much time or all our time only talking about the consent process. That's just like one part of the puzzle. So it's great that people brought up the PLS, the language summaries afterwards, the post-cert, but it's the whole thing throughout the whole study. The whole experience has to be filtered through a lens of how am I going to empower this person that they can ask a question anytime they want, and mostly people with low health literacy ask fewer questions in all kinds of contexts because they don't have the social capital to do so. And if you don't create a space where people can ask questions, they won't ask questions. If you don't get to the questions, you're failing. There are always questions. There's always anxiety. There's always something that you need to get to. If you're not getting to the questions, you haven't finished the job.
That is spot on. Kareem?
Michael, and I so agree with everything you and Monique have said. And I also want to put a plug out there for thinking about the study coordinator. I started off as a study coordinator, and it was in that role as a study coordinator. Before I was a study coordinator, though, I was the co-director of a health ministry at a local church. And it was when somebody brought a recruitment flyer that Silas talked about to our church, trying to recruit for a study, that I got interested. And I said, you know what? I don't want to just be on the outside looking at can I tell this PI, I didn't know what a PI was, tell them that they can't bring this flyer in here, that we actually have a full committee that reviews all flyers and goes through announcements. And there was a process. And so because I had a mentor in Dr. Robert Wynn that said, I'm going to create a space for you, not just to have a voice at the table, but to have a decision-making seat at the table. We talk about power, to go from being that community health worker who had worked in a faith-based organization to a study coordinator, now to the PI where I am. And so when we bring our lived experiences and our full self to this work, we also have to encourage and create spaces for more people that reflect the populations that we ask the questions on and to be a part of those that are asking the questions and the leadership.
Absolutely.
Kind of following up on that, we've heard a number of examples of different influencers or trust brokers or clinical trial champions that we can resource to help address health literacy around clinical education. What is the role of social service agencies or libraries or other kind of community institutions to partner with participants to help play a role in improving health literacy?
So I'll jump in here. We likely fit your kind of description of a service provider, as well as partnering with a number of them. So I would be remiss if I didn't put a plug in here for, if you are partnering with any of these organizations, whether it's a nonprofit, condition-specific organization, or a library, or a local church, making sure that there are significant resources for that community partner is key. Talking about trust and talking about power, I mean, money, where you put your resources is where you put where your priorities are, right? So I just have to put that plug in before I make recommendations around how to include all of these partners. I think it's the role of these organizations, whether they are a information, partner or a recruiting arm or whatever their role ends up being, I think expecting them to be a collaborative and influential part of the process is key, right? So researchers can't expect the library professionals or the local minister to just blindly say, well, yes, do this project because we think it's good. I think having them as a meaningful partner that can influence decision making, that feels comfortable, right? It's that idea of trust by proxy is great, but you have to make sure that you're a trustworthy partner and you're investing in these partners and letting them be part of the process, not just essentially using them as a commodity to meet your recruitment quota. So I don't know if I answered your question, but that's what bubbled up when you asked it.
Let me follow up with that one real quick. And it'll kind of weave in some things that I think Monique mentioned and Kareem and Michael as well as you Rebecca. If we're going to really, drive towards a more equitable partnerships at the community level, right? Engagement is one part of it, but the de-identified aggregated data that comes out, right, that tends not to be shared with these 501c3s that are embedded in communities that are stuck at $10,000 funding levels from their local Atlanta Foundation, Cleveland Foundation, Chicago Foundation, whatever it is, because they don't have data about their own communities, even though they're being asked to participate, right, in research in those communities, is also quite offensive. And so I have to make this a question and not just a rant, right? So what are you guys thinking about some sort of mechanism from a policy perspective to assure that that de-identified aggregated data is made available back to those organizations at the community level so that they can seek their own funding and greater amounts of their own funding?
Silas, I'll kick that off. Someone put in the Q&A too about community health needs assessment. And I am one of those that, because I formerly worked at a cancer center, sometimes because of funding, you're required to do community health needs assessments. But then we began to ask that exact question: for what and for whom? Many of the questions that we ask in these community health needs assessments have already been asked by other entities and other organizations. We're often going to the same populations multiple times to ask the same question. And there's question answering fatigue from community members. And I love what you said. There was one grant where I said, you know what, we have to be able to offer office hours and technical assistance for community members to give this data back to them from community health needs assessment, to give it back to the smaller community-based organizations and say, were you aware that in your zip code where your community-based organization serves, that these are the health issues that you face? We even disseminated data back to elected officials, city councilmen and alderpersons, and they were surprised. Many of them never knew the health disparities of their data. We went into some communities and said, did you know that cancer was the #1 that more men in your community die from prostate cancer than they die from gun violence? I'm not saying don't put all the resource behind, violence and structural violence, but are you also aware of the health inequities that exist? And more often than not, those elected officials will say, Kareem, we didn't actually have the data. We heard about it, but no one had ever gave us this data back and showed us heat maps about what's happening in our community and talk to us about how we may, as elected officials even, be able to think about resourcing up those areas that exist in this heat map that you just showed us. We have to move beyond preaching to the choir and, publishing our papers because we know it's publish or perish, but for who and for why? What's the real community value added to the community health needs assessment? It has to move beyond just checking a box for us to do the tenets of our grant, and it has to provide some type of value to those communities. And yes, I think there needs to be policies for us to disseminate that information back to communities in a way that they dictate and determine is helpful to them.
Yeah.
I agree. And I want to add on to what Kareem just said, because I thought about the fact that there's a lot of community-based organizations that we've had the opportunity to work with. And one of the things is not only do they not tend to have the access to the data that they need, they also don't understand it. So I think there is also another opportunity for not only policy, but also implementation in terms of educating community-based organizations on how to use the data once they get it. How do you use that to improve your projects? Because a prime example would be organizations that are at that 10,000 wall that they keep hitting to get more funding is they're doing really good work. They're doing impactful work, but a lot of times they're not collecting the data they then need to be able to use to inform quality improvements, but also to make the case for funders. So I think we need to do a better job of educating the community on data science and how it can be used for program improvements. But I also want to circle back to the point about how we can make sure, how we can connect this back to social services. And so my early career, I spent working with a home visiting project providing program development and quality improvement. And I remember there were tons of service workers who did home visits weekly with voluntary participants who are enrolled in the program. And one of the outcomes for that program was that they were to make sure that their home visits that they were discussing, well, baby checks and also the vaccination schedule. Well, what I realize now after spending time in the field of health literacy is the workers also didn't understand what that meant and why that was so important. So I believe that there's also a prime opportunity to also connect in those social service fields, particularly those are inside the home, because when you talk about a trust broker, if you allow someone in your home, I mean, how much more trustworthy can they be? We don't just open our homes to just anyone. And so I think there's an opportunity to utilize those models that exist. So whether it's, I can name some of the big ones, which are Healthy Families through the Prevent Child Abuse America, Healthy Start, some of those programs to also discuss some of this information that we're talking about here.
I put in the chat a link to a map of the United States about health literacy. This is data that any local group can use. It gets down to the census tract level. So this can be shared and hopefully help people already start the process to communicate with their local governments about some of these issues. This is not the whole heat map of all the different health issues. This is just for this particular topic. And so I just, maybe that's a resource that people will use. I help create that with some folks at UNC and some other people. I just to leverage off of what you were saying, Monique, and I think Rebecca before and Kareem, I think we need to be creative about who all of the partners there in the neighborhood. And I think there's actually probably a lot of potential partners. It will take sharing the power, like Rebecca mentioned, which is money. But we also can be creative about who can be, a resource for promoting health literacy. I know of some fantastically interesting projects. One is using the Meals on Wheels delivery guys, the people who do the deliveries of food in the homes, and how to work with them because they're going into the home, just like you said, Monique. So, and how they can, help with identifying people who are at risk, social isolation, but also depression and all kinds of other things, and health literacy and advocating for, medication. There's actually all kinds of different models out there. Or you mentioned health ministry, Karima. That's absolutely a great model. Like these are community organizations that say, we want to work on promoting health for our community. We want to help work on decreasing disparities for our community. So that's another great model. There's actually a ton of them. Kareem, you're going to say something.
I just want, and I too, no, I fully agree. And I want to put a plug out there, but and clear it up too. When I talked about trust by proxy, that does not free the researcher up from doing the work to get the trust. I couldn't have gotten in with the community-based organizations had I not had a trusted relationship with them. So when I do work with barbers, it's the fact that Kurt, the barber, trusts me to let me even into his barbershop. There's tons of researchers that come a knocking, but he don't always answer for them all. He answers for those who he trusts, because he knows that once he lets us in, his clients will then say, well, Kurt let Kareem in. If Kareem is asking this question inside this space, Kareem must be cool. And so that's what I mean by trust by proxy. It's in no way to free up the research community from saying, get someone to trust you, but for you to do the work so that you can have a trusted network as well. So.
Yeah, because Kareem, those people that let you in are putting their reputation on the line, right? And once you partner with somebody who has been, burned in the past, it's even harder to get those doors to open. And we've experienced that as well. So that's a nice clarification. And I was not accusing you of not doing that. I just don't want to put tips out there in the world without that context.
All right. This was unbelievable. This was a great panel. I just enjoyed it thoroughly. Amanda, I won't speak for you. I'm sure you enjoyed it thoroughly. We are up on time. I just want to give a heartfelt thank you. I think we'll remain in touch with everyone here, right? I think we may, knock on someone's door at national academies and see what we can do about having these sorts of conversations more frequently, and maybe actually come to some sort of action, collaborative, or working solution that we can all put our shoulders to the wheel around. With that, I'll say thank you and pass it back to Amanda to close us out. But thank you, guys.
I'll also add my thanks for your wonderful discussion and your time this afternoon. And also for the audience, thank you for all the questions you're putting into the chat. We didn't have time to get to all of them. But at this time, I want to hand it back to Dr. Smith to share some last bits of information with our audience and close us out this afternoon.
Okay, well, I really want to say that this has been an amazing workshop. And I want to thank everyone, the presenters, the panelists, and the audience, but it was truly spectacular. And we will all go home now thinking of the many things we have to reconsider as we move forward. Thanks to the moderators, the audience, who we could not have done it without their questions, to the National Academy staff for organizing this workshop. And as a reminder, the recording of today's workshop will be posted to the event webpage 1 week from now. Please check back there if you'd like to rewatch any of today's panels or share them with your colleagues. Lastly, if you'd like to receive emails about future webinars and workshops, please sign up for the listserv with a roundtable on health literacy. We hope that you'll join us again soon. Thank you and take care.